But thanks for your time, guys. I know you guys are all super busy, so it means a lot that you came here and are willing to chit chat for a couple hours about stuff.
Thanks for having me.
Usually the way I start is just we'll go around to say your name, credentials, how long you've been in emergency medicine or education, and then we can kind of talk about some stuff. We can start with Kate.
Oh, right now?
Right now.
Oh, I'm so sorry. Okay, so I'm Kate, and I am an EMT, and I've been in emergency medicine for a little over a year now. So still pretty brand
That's
new.
right. I forgot you're pretty brand new.
Pretty brand new.
I love it.
Did pediatrics before that. And
Awesome.
And is your goal eventually PA or is it paramedic? I forget.
PA was paramedic, and then Nick talked me out of it, and he's like,
Okay.
just go straight to PA. So it's PA school is the goal, but I just keep getting an itch every single time, or there's an AEMT just to get a slightly bigger scope all the time.
Yeah.
But I think PA is the ultimate goal.
The hard thing I address with EMTs or paramedics that want to go to PA is a lot of medicine doesn't know the difference between the two. So I don't know that it necessarily helps you that much. It does practically for sure,
Absolutely.
but when you're applying, I think a lot of these PA academic people see EMT and paramedic and they have no idea what the difference is. So I'm like,
They don't.
sometimes that's the advice is just work on getting into PA school. if that's
Paramedic
the
would
end
just
goal.
be purely so I enjoyed my day-to-day job, or just because
Yeah.
once I'm like, all right, I think I have everything I just learned down, and then I would love to be able to learn more or expand more, and that's you're so restricted with scopes, which makes sense. So I would love expanding on it would be purely out of interest. It's just like a very expensive interest.
Yeah,
so
for
it's
sure.
better
Yeah,
just to go to
it is.
PA school.
And
I
time
think.
consuming too.
Oh
Right.
yeah.
Yeah.
We have a lot of conversations actually with PA schools to educate, and specifically though in Colorado, it's hard to branch out nationwide to have those conversations of differences in scopes. And the fact of the matter is, even in the medical field, people as a generality that we interact with on a day-to-day basis don't understand the differences in our levels of care.
Oh, I get called a medic all the time.
Yeah.
I'm like, well, that's not really it. And they're like, what do you mean? I'm like, I don't know if you'll understand why I tell you. Like, that's a completely different level of schooling.
Yeah.
So, but I get lumped in all the time.
Right.
But, there's no way for them to know without
Right.
it being broken down for them.
Yes.
Well, how many of our providers are like, they, get a really bad report, and I'm like, well, did you look at, was it an EMT patch? Are they brand new? Have you
Right.
ever seen them before? Or are we
Yes.
talking Casey, someone who's been a paramedic? Did you look at their patch at all?
Yes.
'Cause it makes a difference if they're a brand new EMT and you can tell they're third riding or orienting. Like, I have way more grace for their report than someone who's been a paramedic for a long time. Because if that happens, then sure, they should have given a better report. But most people just don't know. It's weird. Even the emergency physicians
Yes.
don't know.
I get asked to do things kind of out because no one really knows my title right away unless I work with you guys a lot. But people are like, are you able to do this? No, I don't think so. And so there's a lot of gray area there too sometimes, or just when you're moving so quickly,
Yeah.
you don't necessarily know, and it's different between in the field and then in the hospital too.
Absolutely.
So it's
Absolutely.
really hard to remember exactly what you're allowed to do and where those rules are okay.
All right, Kim, why don't you introduce yourself before we get too carried away?
Sure. So I'm Kim Whitten-Chung. I have a doctorate of education and higher education leadership, curriculum development, instructional design, and assessment. I am a licensed paramedic in the state of Colorado. I am a fellow of the Academy of Emergency Medical Services, and I am a certified healthcare simulation educator.
That's awesome.
I try to be involved in many things to represent EMS in our city, state, and actually both nationwide and internationally. I have been in EMS in some form or fashion, very depressingly, for about 27 years.
27 years.
That's we were having the conversation. Actually, the only reason I know that right off the top of my head is because we were having the conversation with my students right before they went into their internship, my paramedic students, right before they went into internship just a couple weeks ago. And that's longer than some of my students have been alive. I find as well.
And you were my EMT instructor back in 2008.
Yep.
A brand new baby EMT.
Yep.
Aaron got his EMT.
And
and paramedic in, I think, 2011, probably through 2012.
In fact, I still have the board in my office that has your paramedic picture on it.
That's unfortunate.
Oh, yes. I should have taken a picture of that before I came. And so, yes, I still have all of the memorabilia of your, and I bet if I looked, I would still have pictures of you in EMT.
There's also a horrible YouTube video.
No,
that
it is
we
my
made.
favorite.
Oh.
I love
I've
that
seen that
video.
one.
Oh my
I
God,
love
it's
We made a
so
parody
amazing.
of a Katy Perry song we called it Paramedic's Dream instead of Teenage Dream.
Phenomenal.
gosh.
It is a phenomenal
That was about,
video.
Aaron was about 40 pounds heavier in that video, dancing
What's
on a
paramedic
table.
school, right? Like you
Yeah.
can't get away. Yes, so good.
Hopefully that video, I don't think I even know the account that I put that video on, so I don't think I can even delete it off of YouTube at this point. It's stuck on there.
I hope not.
It's absolutely.
I should be
the first
making
thing I'm
money
doing
from
when I
that
get
video.
home.
Oh,
Finding this
without,
video.
yeah.
Oh my gosh.
Paramedic's Dream. It's going to come right up.
Oh
It's
my
so
gosh.
good.
Yeah.
It's,
bunch
actually
of those
old school
guys.
paramedic program.
Yeah.
It is phenomenal.
That will not be linked in the show notes.
Everyone should search it.
All right. Tracy, what's your background?
So I am currently a physician assistant. I've been working in that role for about 7.5 years. Before that, I was an EMT and then paramedic for about 14.5 years before I went to school. And I took an EMT class when I was in college because I wanted to be in medicine. I wanted to go to med school. Some family things happened that didn't work, which is fine with me. But I ended up doing a third ride, and like the old cliche of like hearing angels sing. Like I remember just stepping on the ambulance, and it was just I was home.
Mm-hmm.
Loved it. I loved it, and I couldn't not do it. So there I was for almost 15 years, before I went to PA school.
Yeah.
And I'm so grateful to be doing what I am now, but that is what solidified my love of medicine,
Mm-hmm.
specifically emergency medicine,
Yeah.
because it's just nothing like it.
Yeah. Yeah, I remember my first third ride. I think it makes a big difference who you third ride with, too,
True.
initially, too. I rode with Corey. I guess I won't say his last name, but you guys know him. But And he just made it such a great ride. Like, he loved having students. He was like, come get in the back. I'll show you how to start an IV. And I was like, whoa, this is crazy. And, like, he forced me to, like, give report to the nurses. And, like, he made it so fun and so scary. But
Yep.
the uncomfortableness was, like, pushing you out of your comfort zone. Like, they actually wanted to include you and make you do something. Whereas I think it makes such a huge difference. I mean, you probably hear from your students all the time, like what a difference the paramedic preceptor is, or what crew. Because
Absolutely.
if you get somebody that's super burned out and they don't have the right mindset around the job, it really can ruin your experience. But
Yes.
Absolutely not.
Yeah.
I'm
all
gonna
right,
go home
let's
and tell
catch
my wife
up. Let's catch up
He knows where to
with
go.
Adam, who's here. Can you introduce yourself and say your length of time in emergency medicine?
My name's Adam. I'm an ER physician. I have been in emergency medicine for coming up on 10 years now.
And you were in EMS before.
I was about 21 years ago. I started as an EMT, fell in love with the medical side, let the fire department put me through paramedic school, decided I wasn't alpha male enough for the fire department, and moved on.
I find that surprising that you thought you weren't.
Yeah,
alpha
people
male.
say that. You might be surprised. Yeah.
Tracy, you were telling a story. Can we go back to that?
Yes. Oh, I was telling you about my
Goat farm.
Yes, I was on the ambulance just a few days, and I went on my first cardiac arrest to a goat farm way out east.
Okay.
And I was saying that first of all, the patient did not survive. However, I couldn't find anything in the bags. I didn't do my homework prior to that, and then I left the doors open of the ambulance, and so thousands of flies entered.
Oh, yeah.
So I spent
yeah.
my entire time, probably about 40 minutes, driving back into town, because I was in the back, and with a rolled up magazine, just killing flies, and with this gigantic smile on my face, just happier than anything. I mean, I felt bad for the patient, of course, but I was like, this is where I'm meant to be. I loved it. I loved killing every one of those flies, and it was great. And then, of course, the first thing I did was, after the flies were dead, is look through all the bags and figure out all the things I didn't know where they were.
Yeah.
So that was a great lesson for that too. But
I've learned that lesson a few times too,
humbling.
especially out
Very.
east in the middle of nowhere.
Yes.
At night, all the lights
yeah.
inside the ambulance. Oh man, you got to get those doors closed quick.
Yep.
One time we flew a patient off in a helicopter and had the doors open, and it was dusty and dirty. Oh man, it was everywhere on the
only
inside.
do those-
of the
make
ambulance.
those
Dust,
mistakes once.
dirt everywhere. Oh, I was so mad we did that. I was like, what were we thinking?
Yep.
Oh gosh. First, while we have Kim here, I just wanted to kind of catch up with you and have you talk a little bit about where paramedic education's going, the stuff you've been working on.
Sure,
I've caught a
yeah.
lot of it really peripherally, but I'd like to hear more about it and like how we're educating paramedics now.
Absolutely. Absolutely.
Whatever you want to talk about regarding
Yeah,
that stuff.
happy to talk about that. So I've had the privilege of educating paramedics for the last 16 years. And as you can imagine, there's been a lot of changes. A lot of changes in not only the national curriculum that's been used, of course, but I think changes in our approach to the way that we teach paramedics and EMS in general, and recognition in the idea that testing, the way that testing is done, was perhaps not the best way. In fact, as of the 1st of July, the National Registry testing is going away from the psychomotor assessment. And so AEMTs and paramedics will no longer do the hands-on psychomotor assessment that everyone in this room has done.
Okay.
And so a couple of years ago, actually, National Registry removed the all of the summative psychomotor assessment sheets that everyone is used to doing. So the idea that you walk in and everybody's like jazz hands, BSI scene is safe, right? And which again, everyone in this room is familiar with. And so that is I don't want to say no longer. That should no longer be taught in any classrooms. I am certain that, of course, that it is, because it's really hard to go away from teaching in a way that we were taught.
It's
And
ingrained.
yes, it is, right? And so it should no longer be the practice, but I am certain that it is, if you looked in some educational programs, you would still find those summative National Registry sheets. It took me a long time, actually, and very deliberate conversations to get those out of my classrooms, because my instructors really wanted, they're comfortable with it, they're familiar with it, and so it took time. So we've moved away from, and many programs are moving away from, the idea of like, I walk into a classroom, I open my brain, and somebody's going to insert knowledge into that brain. And which is very good, because you have about 20% retention of information with that style of learning.
That sounds about right for what I feel like I will retain.
Exactly, right? And actually, I had always said to my students, right, you guys remember 20% of what I tell you, which means 80% is lost. Which is why the foundation of what I would give my paramedic students was so robust, because I want that to be a very robust 20%. However, now in our paramedic program and many paramedic programs, we have a flipped classroom. And so our learning is very seldom lecture-based. It is all active learning, very heavy simulation. We give the students their topics in advance. They do their pre-work before they come in, and then they come in and it's tabletops and simulations and scenarios. And then all paramedic programs, AEMT programs, and many EMT programs are now creating portfolios where instead of like, the students come in, like when we were all in school, actually, you would do like a skill and then you'd demonstrate the skill. Now we are very specific with the concept of deliberate practice, where instead of saying, and we still have to say this because of our accreditation, but we have to say that students, for IV starts, for example, a student maybe it takes me 20 times practicing on an arm before I'm ready to go test off, but maybe Tracy takes like 2 times. That's deliberate practice. And we have to understand that with the idea that I've got an instructor there overseeing the practice as well. So it's not just that Tracy and I are going to hang out in a room and start IVs and nobody's watching what we're doing, right? I've got someone there, a paramedic that's there watching what we're doing as well, correcting our techniques in the process. And then we're ready to go test off. But we put the onus on the students to say, I need to have more practice with this, which is incredibly important, right? They're also going to have that responsibility once they go into the field, because they need to say, I haven't done this skill in a while. I need to go practice it. They need to maintain that thought process throughout their entire career, because we really don't want them doing something that they haven't done in a while. That's incredibly dangerous to the patient. So they'll develop this portfolio. Everybody's deliberate practice skills are going to be different, but we have to set a minimum by accreditation standards. Then they have to have their instructor check off. They still have to have the clinical skills that they perform within the clinical setting, and then they have the other terminal competencies that are performed during their clinical and then eventually their internship time. And so paramedic education has really shifted from a hours-based education. It used to be you had to complete 500 hours of internship, and to a competency-based education, which quite frankly is a much better assessment, and they're actually seeing more patients and more specific types of patients than what we saw when we were going to 500 hours of internship.
So their internship now is more, once you've got all these competencies done, you're done.
That's
so theoretically, it could be shorter, it could be longer.
That's correct.
Okay.
That's correct. And in fact, it is generally shorter than 500 hours, but more thorough than the 500-hour internship.
Okay.
And so there is some resistance to that,
Right.
because people are, again, it goes back to, we are ingrained with this concept
This is
of,
the way we've always done it.
that's exactly it. We've always done it this way, so why would we change it? But when we have the data that demonstrates, well, this is what these students are seeing, then we can actually quantify the robust education that these students are now receiving.
Interestingly, on that same note, that data exists in med school literature as well. Over the last few years, there's been a huge shift towards increased burden of education on hands-on application and practice of what you teach in the books, to the point where it has always been med school's 4 years, 2 years are in the books. Doesn't matter if you're bored, doesn't matter how you retain it, doesn't matter what your learning style is, you're getting lectured at, you're memorizing rote information as much as you can. You're buried 4 weeks to 12 weeks at a time in a block, and you're not leaving the classroom for 2 years. And now you've got about a year and a half of the last 2 to get your clinical practices in every field of medicine. And then you've got 6 months to focus on whatever you think your specialty is going to be before residency. And our particular state that we're in now is one of very few in the country that have started to accelerate the learning towards the clinical side and move that forward at least 6 months, if not after the first year itself, to where there's a dichotomy between book time and clinical rotations. They're calling it longitudinal curriculums, and they're putting students out there, out of the classroom, learning their skills, going to different areas to see people and apply what they've learned far sooner. And the data over the last several years alone has proven that it seems to be quite beneficial by the time they hit residency.
Absolutely.
Yeah.
Some of the partners that I work with actually are medical schools, and we focus specifically on incorporating simulation into their curriculums.
That's a biggie.
And so that's, again, very deliberate in what are the patients that they are going to see very infrequently.
Right.
And so how can we build a curriculum around those specific patients, identify the objectives, and then incorporate that into the education for these students?
Yeah. Without going down a huge rabbit hole, I would say that's a whole nother podcast on learning styles,
Right.
teaching styles, but you nailed it. I mean, all of medical education at every level, doesn't matter what position we're talking about, the benefit that should be taught is on simulation, especially with modern technology that's out
Absolutely.
there. And in all honesty, there should be time spent teaching on visualization practices. in
Oh
my
yeah,
opinion.
absolutely.
It's a game changer.
Absolutely.
Yeah.
I don't know if this helps. I went through EMT school back in 2013 when I was in high school, and that was in Virginia, so it was a different scope.
Yeah.
And then had my daughter, my license expired, redid it out here about 1.5 to 2 years ago. And I don't know where you teach, but that's the simulations was my entire education. Was they put you in this room with a two-way glass, and then you look at vital signs, and based on your vital signs, there's no one going, your patient is now no longer breathing, or like the first psychomotor, because I didn't do a psychomotor either here, but I did it back in Virginia. It's completely, you have the dummy, and then you have your life pack, and it's, on there, and you're reading their vital signs, and that's what you're going off of. Or you go, I'm looking at my patient's pupils, and then someone on the other two-way glass is like, one's, this is what they measure at. And it was, I felt so much more prepared, and I was half attributing it to the fact that I had done it before, roughly, but it is a completely different way of learning, because you're in there and there's no guidance. It is, did you learn, did you retain, did you, and you can see, and then you debrief afterwards. And then my instructor at the time was like, hey, this was something you guys could have focused on, what could we have done better? And it's like just the hands-on practice with observation skills, with this felt funny, or I didn't like this. And then you're with 4 people like a team, and you have that back and forth, and then you have that, one person's like, I want to do a traction split, and you're like, I had no capacity do I want to do a traction split on this person, or like, I want to test the pelvis. And so you have that practice, which my first 10 years ago I did not have. And so I remember my first job back in Virginia, I walked in and it took everything I had not to walk on scene and go, BSI scene safety, don't hurt me.
Your jazz hands.
Oh yeah. And so
I'm going to guess you went to Pikes Peak.
Yeah.
Yes. So that is my program.
I have emailed you so many times. I have. You respond every time. It's really
That's
nice
good.
to meet
I'm really glad
you do. It's really nice to meet you. I was wondering. I was like, man, I wonder if this is this woman. Yeah.
Wonderful. And actually, you bring up a really important part about the debriefing. And so that brings us to, there's multiple educational theories that support the use of simulation. Simulation is an umbrella, and I'm really sorry to derail here, Aaron.
No, you're fine.
Simulation is an umbrella, and there's different levels underneath simulation. And so first we have the deliberate practice that I spoke of previously. Then we have scenarios that we run under simulation where we don't necessarily meet all of the healthcare simulation standards of best practice. And then we have the simulation, which is where we put you into an environment that we ask you to suspend disbelief that looks like the environment that we're going to try to that we expect you to be walking into, such as the apartment or the ambulance.
Yeah.
And so my job now is I've transitioned from teaching paramedics to I'm the director of operations for our Center for Healthcare Education and Simulation. So I operate a $100 million simulation center.
Wow.
I feel like I'm fangirling now. It was the raddest thing I've ever seen in my entire life. It was so amazing.
Yes, I would love
we
to
did it a
have
little
you.
in PA school, but very little in PA school. And they had a pretty expensive setup, but we hardly utilized it at all.
This was everything.
Yeah.
Everything prepared me for hazmat situations. If you walk into an apartment and you're like, oh, they mixed something in here they weren't supposed to. And then just observations, I think my instructor would put a toy weapon somewhere. And it's hey, you didn't realize, or you learn how to negotiate with them, when to call PD, when to do that. And it just so much more prepared. So I felt coming into the hospital or dealing with anyone, it wasn't so anxious, and I wasn't looking so much for like textbook, because you know, like, is this patient presenting as this, and this? It really got me out of that black and white method. It gave me a lot of way to comprehend gray area of what could actually, you know, the index of suspicion, like what could be going on here. And that, I mean,
I love
oh my
hearing
gosh.
that.
No, I'm so happy to meet you. It was the best.
Wonderful.
That's why I miss school so much. I go back and I was watching my friends in the AEMT program. I'm like, man, they have like a fake ambulance. So you ride in there and then they let you go off and you practice loading and unloading. You practice working in an apartment, on scene, off scene. So you get to decide better that stay and play mindset. You're sitting in there sweating and stressing the whole time. And it was just, it's great. I love it. If y'all can go back and look at it.
I'll have to go check that out.
I have a way to bring you back. You can come work for me.
I would love to.
Yes.
I would love to.
I
It's
just
my
lost an
favorite.
excellent tech in the
Yeah. We got,
You brought up,
part-time work. Like, she could work around her current schedule. So
Oh, I would
yeah,
I'd make anything work. I miss it so much.
All right.
But yeah, if
Deal.
If there is a way to implement that to medical
Yes.
school or PA school, in a heartbeat. In a
Well,
heartbeat.
one element too you talked about a couple episodes ago was like the de-escalation techniques too for like even just medical patients that are a little aggressive or whatever, and all the de-escalation stuff, which I mean that's not what we taught when I was in EMT school, which is something we encounter every
very
day is like
different.
how to
Yes.
talk to people.
I was
Yes.
like affect is what I was bringing up,
Yes,
and
yes.
that's one of the scenarios that she was talking about. Would be a simulation or scenario. My instructor would put me in a room with like a nonverbal patient or someone that is intoxicated, and the entire job was just to bring them back down to my level. And then as soon as I got permission to like get a blood pressure on them, she was like, done, in a scene. That's all you have to do is learn how to talk to people.
Yes.
And that's what we were talking about how different that is for the past decade. And so I think my repertoire with people that start off up here, I for the most part can bring them down to here. Some people are inconsolable, but it gave me the to not panic the second someone starts getting their voice loud. I'm like, hey, why are we upset right now? What's going on? You know,
Such a key thing that we do so often.
oh yeah, all the time.
And I feel like, if it wasn't taught in school before, you either gradually learned it over years of practice or you didn't learn it over years of practice and you
it
ended
burns
up
you
with,
out. Yeah, getting yelled at
if
all
you're
the
just
time.
escalating
sucks.
patients every day instead of being able to de-escalate them, that's like a huge burnout component is
Yeah,
you can't
absolutely.
de-escalate somebody. Or even just talk to somebody about their discharge stuff, which is what we do a lot of, is like if you can't read the room and see that this patient needs a little more time, you need to take more time to explain this. Some people don't need any explanation, but some people you have to be able to read them if they need that. Otherwise they're going to be very unsatisfied even if you provided the best care.
Right.
You know, if you can't explain it to them in ways they can understand, you know, it doesn't matter if you did everything right. You know, they're going to say it was bad care.
Oh
you know?
yeah, just absolute, because people will come in all the time going, this is what I need, and like that it's actually in no capacity what you need, and it's taking those extra minutes to sit down. I'm sure you guys have to do it all the time. I have to do it in like micro amounts throughout the day of this is why you do not need, or this is why we're not doing the MRI. You know, if you want to do it later, this is the reason. This is what you came here for. This is what we provided. So being able to do that and get it in a way that they understand, because I can throw terms at them all the time and they aren't going to understand. So doing that is and then not telling you you're bad at your job all the time is
Everybody thinks that part of their education feels a little extra stressful and silly. You know, they always complain in general. The average person in medical education of any level complains, you know, well, we had these sims today where we had to go over interactions with patients and de-escalation techniques. If you don't uniformly teach that to the general population in some regard for them to have some tools in a toolbox, whatever they're going to do with it, and you leave everybody up to their own personality to decide how they're going to handle those moments, bad things happen, I assure you, because some of us are not wired for de-escalation. It's just not going to go that well if you don't have a backup program.
Sometimes I can't de-escalate my toddler.
That's what.
Yeah, true. Speaking of daily practice,
Which is great practice.
Right.
It is. It
Yes.
is. We have a lot of toddlers out there.
Yeah, very patient, or just learning how to speak to someone and or like getting respect back. So it's been. I was not a patient person before I started that in any
Ironically,
capacity.
you can
kinda
use
have
it in
to.
your day-to-day life. We went to a concert last night, and
on the way out, of course, there's a lot of traffic, and there was a poor gal in her car that was having a panic attack. And so I left my vehicle and de-escalated her panic attack.
Wow.
Much to the concern of my 17-year-old daughter, who thought I was going to get shot.
Don't talk to her.
Right,
Yes.
right.
Well, that is a concern these days. Yes.
And of course it is, right? But
Speaking of reading the room,
people
though.
are in need everywhere you go.
That's
and-
awesome.
That happened to me on an airplane once.
Really?
Yeah, I was
the
waiting for
airplanes.
everybody else to raise their hand when they asked for medical.
They asked for medical,
They
and
did, and I was in the very back of the plane, and nobody raised their hand. I thought, oh, okay. And then, this guy was just having a panic attack, but he kept saying he had a terrible abdominal pain, and they kept asking me, "Do you want to land the plane?"
Yep.
I thought, "No, I do not want to land the plane."
That's
We're
why
gonna
you
continue
raise your
on,
hand. You
know?
want to go.
So, I don't know.
Yeah.
you better have peritoneal signs if I'm gonna.
You better be
He
dying.
certainly did
Yeah.
not. So we continued to.
That's right.